Good evening, friends. I'm very happy to be part of this entire event today, and also very happy to introduce my dear friend, Dr. Vijay Richards, who is a senior consultant at the Narayana Hridayalaya Hospital Health Systems in Bangalore, and he had his undergraduate training at CMC Vellore, and he went to UK to do his post-graduation in internal medicine, and then his special interest to clinical microbiology. He did his FRC path in the UK, and he was a consultant there until 2012. And he came over to Narayana Hridayalaya at 2012 to take up as a consultant microbiologist, and an amazing clinical microbiologist who implements practices and implements guidelines as per the requirement. And as a hospital that's been accredited with GCI and NABH, he has so much to offer us. And it's always a pleasure listening to Dr. Vijay. Over to you, Dr. Vijay.
Thank you, Dr. Jayalakshmi. At the outset, I'd like to thank the CAHO team, the entire team, and the organizing committee for inviting me to give this talk. There are a few slides, and then there'll be a little bit of practical demonstration with common items just to take the point home. So without wasting any time, just going to the next one. Single-use devices. Why has it got its name? As we all know, the manufacturer has intended that this device will be used only once. So the manufacturer is not going to tell us this device is made of this material, you have to clean it this way, you have to sterilize it this way, this is not compatible with this. It's all entirely up to whoever reprocesses it to figure that out. Reasons for reprocessing devices. Now, the main thing is cost, as we all are aware of. Availability. Sometimes a device that a surgeon needs, or a cardiologist needs, or any other specialized technique requires, may not be available all the time. So what we had earlier, what we had 2 years ago may not be available now. The next thing is the quality of items. I would definitely say there are certain items which are there 2 years ago are not, which are also, you get a similar item now, but the quality issues are present in certain items from certain companies. So availability and quality issues will also force us to reprocess the single-use devices. And another reason is to decrease medical waste. Goals of reprocessing. We want to make sure that our reprocessed device is as safe and as effective as a new device. It should be safe from the risk of infection, free from organic matter. Most importantly, it should do what it's supposed to do. If it's clean, sterile, and doesn't work the way it's intended to be, then it beats the purpose entirely. So developing countries, there are a lot of guidelines and a lot of regulations in all developing countries where they reprocess these devices. Very stringent method of reprocessing, monitoring, and they also have a market clearance. US FDA, there is Government Accountability Office, the GAO in the US, they regulate and actually monitor the reprocessing of these devices. In addition, you have large third-party reprocessing companies. These are huge companies on its own. They have streamlined process, state-of-the-art equipment, and it's exactly like the factory. I like the picture that one of the previous speakers showed of a car factory. So these third-party manufacturing agents are just like that. It's like a big factory. And they have well-established quality assurance programs. For instance, they have large automated washers. And if you just zoom into that, this is what you see. You see large high-pressure jets here. So all the luminal devices can actually get slotted into these jets. And you can imagine the degree of pressure and the cleanliness, organic matter will come off. Indian scenario, we don't have national guiding or regulatory authority which is strict on reprocessing. We don't have easily accessible and very importantly, reliable third-party reprocessing companies. Each hospital has to reprocess their own devices. There's lack of automation. A lot of it is being done manually. No external regulation, and the quality assurance is in-house. So what do? All of us in hospitals, we do what we consider is the best with the given resources, and we do all the best to make sure our patients are safe. There are many correct ways to reprocess devices. So just going through a practical approach, first of all, there should be a committee for reusing single-use devices. The committee should have the end users. The end users, please include the technicians, the doctors, the nurses in that particular area who use the device, administration, infection control, CST. This would be the bare minimum for the committee. And every device which needs to be added on, every decision which needs to be taken for single-use devices should be passed through a committee. There should be a very clear written protocol about the process flow, the steps required, the items which can be reused, and the maximum number of reuses defined per item. Lots of training, adequate space and resources, which have been talked about earlier, quality assurance, including mock recall. Staff safety is a paramount. For lack of time, I'm not going to go through it, but we all know this is very, very important. This is just an example of a process flow. Reprocessing single-use devices can be very challenging, very complex. So this is just an example of a process flow. The details would vary from each setting. So once a new item is got from the stores, its functional integrity is tested on the table. So it's a sterile item, it's checked on the table. If it's not used, it gets discarded. And then it's used, it has its primary wash. A unique number is generated after reuse. I'll come to the unique number when I do a little practical session. Functional integrity is tested again, discarded if not useful. It goes for a screening enzymatic wash, another functional integrity check, drying, marking the number of reuses, packing, sterilization, storage, and then use again. So that's in general what a process would be. Different hospitals will have different parts of this being interchanged based on their scenarios. Once the device is used in surgery, primary wash happens as soon as possible. Importance should be given to flushing of lumens. Again, a lot of it is done manually in our country, so a lot of training is needed, supervision is needed, personal protective equipment is needed. This is just an example of what I showed you earlier. This is the jets which are used to clean the luminal devices. We can improvise. India's excellent in improvising, have a high pressure line with good quality of water, and have, this is what we have done in our hospital. We have multiple outlets. So in each outlet, you can fix one luminal device. And once you open it, you get a good force of water, and that would be equivalent to what is done in the West in a cost-effective manner. Further cleaning by enzymatic solution, either manually or ultrasound guided, assisted. Important to follow the recommended dilution and contact time as mentioned in the previous speaker. Very important, once the solution is used, kindly discard the solution. Don't put another batch in a dirty solution. Thorough rinse and dry completely. Compressed air, medical grade compressed air, which has been spoken about in one of the earlier talks as well. Functional integrity check, very, very important. I would just, I don't know if you can see me. I'm just using a wire to show. So imagine this is a cannula or a catheter. It needs to, first of all, have no cracks, no leaking. It should have no kinks. If it's kinked like that, as you can see, it will not serve the purpose. So the functional integrity check should be done by the end user in multiple levels, multiple areas, and it should be pliable. Now, this catheter is supposed to be pliable. It should go into different crevices and go along the vessels. But if it's straight and rigid, it will not work. So it should be discarded. So functional integrity check should be robust. It should be documented. It should be done very diligently at multiple levels. Then packaging, sterilization, and storage. How can I protect my patient? That's the most important question we all ask. Ethical issues, we are responsible for reprocessing because the manufacturer will wash their hands. It's not their issue. We have to inform the patient about reusing single-use device, obtain consent. Patient has the right to refuse. Quality assurance, your functional integrity testing at multiple levels, as I mentioned. Then defective items to be discarded, and please maintain a discard register for accountability. A lot of these items are high value items. There should be accountability of discarding as well, and a reason for discarding. Maximum number of reuses will be decided by the committee and fixed. Even if the item passes a functional integrity test, do not exceed the agreed number of reuses. Quality assurance, we've talked about cleaning indicators earlier, and ATP, I will not waste time going through that again. It is dealt with very well in the previous sessions. Sterilization indicators, and also which should help us doing cultures from reprocessed device after storing it for the shelf life. Now tracking, this is where I like to spend some time, tracking reprocessed devices. We should be able to identify patients in whom the device was used previously, either manual records or barcodes, very important from the clinical and from the medical legal perspective. Okay, so in tracking, one important thing is how will you differentiate between identical devices? So I would request you on your systems, if you can just decrease the size of my presentation and increase the size of me. I have got multiple items which look very similar. These essentially are all pencils. Suppose I had only two items, it'll be very simple. If I've got multiple devices which look similar, how will I differentiate one from another? Okay. So just for clarity, I've got 20 items. Okay, so we've got multiple devices there. Now, how will I know this device is different from this device? So for that, there are two ways. One is to put a mark on the device. So if it's there and this end is going to the patient, put a mark on this end, which should not leave any cracks or should not damage the item, but it should be legible. Very simple, a thin permanent marker pen, not a thick marker pen, because it can also it can prevent the surface from being smooth and cause problems in cleaning. A thin marker pen on the device. The other thing you can do, if you're able to, is the packaging. You've got your device in the packet. On the package, give it a unique identifier number. So what we follow is we start, suppose for instance, this is a 6 French catheter or a cannula. We start calling it A, the next one will be B, C, D, so on till Z, and then start with AA, AB, AC, just very similar to the vehicle registration system. So that will be on the packaging, and you can also note down the number of times the device has been used. You can see 2 tally marks there to denote the number of times the device has been reused. It's been reused twice. You can figure out your own way, but let it be uniform. If you cannot do it on the wrapper, you will do it on the item itself. If you're doing it on the wrapper, it is very, very crucial, extremely crucial, that the wrapper and the item should go along with each other for reprocessing. If this goes somewhere and this goes somewhere, it's going to be a nightmare and we cannot track it. So if you're able to do this and track the wrapper against the device, please use it on the wrapper. It's much easier. If you're unable to, please make a very careful mark on the device itself. So that's about how to differentiate between items. When we track the number of reuses, as I mentioned, the tally marks on the paper or on the device, or dots or colors, everyone talk about it. So that you can use whatever, but whatever you decide as a committee should be uniform across the hospital. Okay, next part is very difficult, tracking the patients on whom this device is used. So this item, which is labeled AN, for instance, has been used 3 times. Who was it used on before? So it's paramount that someone actually writes it down and documents it either in a physical register or an Excel sheet or whatever software you may have. It's very practical for this tying the device to the patient to be done in the clinical area, end user area, because the CSST will not be able to do. CSST will know this device has gone into this batch, into this sterilization load, and have the quality assurance for the sterilization. Whereas the clinical area, cath lab or OT or wherever, they will know this device has been used on this patient. So very important that people in the clinical area do tie up this device, single-use device, with a patient. Very simple example is if you got a sheet, a page, which has all your master, we call it a master register. We give extra space for them to write down the details of the device. Sterilization labels are also stuck there, so that it's very easy for everyone to track back. So 1 year down the line, I want to know where is AN used, how many times was it used, who has it been used in. We can actually go back and find this, and the records to be kept safely. I would encourage everyone to use something like an Excel sheet, because we used to have manual records, but an Excel sheet has made it so much easier. Okay, so possible way forward. I mean, the West is doing amazingly well because they've done it for many years. It doesn't mean we cannot. In fact, a lot of innovations have come from India. So input from various academic bodies and societies, so cardiologists, surgical teams, perfusionists, all of them to frame practical guidelines, not guidelines which are impractical, and detailed protocols which are easy to follow and which are robust. National guidelines and regulations very important. And I think we should move towards third-party reprocessing with accountability. Another thing could be having hospitals group together according to the region and try and work together towards this. So in summary, we've looked at the reasons for reprocessing, what happens in the West, what happens in India, challenges and practical scenarios for Indian scenario, solutions for Indian scenario, quality assurance, and the way forward. Some of my references. Thank you very much for your time. And this is a difficult thing to do, but I'm sure once we start it, it'll be possible, and you will automatically innovate and find your own ways to do it in your own hospital. But important is to start methodically and follow the method, do random audits, surprise audits to make sure that people are doing the whole thing properly. Thank you.
Thank you very much, Dr. Vijay. An excellent presentation as always. Thanks for that wonderful practical demonstration. I always enjoy your practical demonstration with material around you on what's on your table. All right. So wonderful, wonderful. You choose the number of times that an equipment goes in for or a device goes in for reprocessing? And is there some guidelines that can help?
Okay. First thing is, how do we choose the number of times the device can go in for processing? That would very much depend on the material of the device and what has been happened. So suppose I've got this device, I'm reprocessing it for the first time. I will check with other hospitals, or I would ask my colleagues in the clinical area from them also, how many times have they used it in other areas? I won't start with 10 or 15. I would start with 3 or 5. Start small, see what happens, fix it to either 3 or 5, see how it goes. Sometimes I may fix it at 5 reprocessing, but on the 5th or 4th reprocessing, I notice consistently functional integrity is breached. I may bring it down to 4. Or if it doesn't survive 3 reprocessing, you would review your number of uses and bring it down to 3. So it's a lot of trial and error. That's the only way, because the person who uses it also, there's a lot of two-way communication required. So I would tell my cardiologist or my perfusionist or the surgeon, let me know if one particular device didn't work. And if they say these devices are not working, you get a pattern. So on the 8th use or 4th use, they're not working well, you will automatically decrease it, that they're not faced with a situation where it doesn't work well. Because the last thing you want while doing a procedure is that device failing on you. So
yeah, thanks, Dr. Vijay. There's another, in fact, there are 3 questions of the similar kind. How you track each device against each patient, or how do you, match the patient to the device to that number of times that the patient has, number of times the device was processed before used on that particular patient?
Okay, that's straightforward. So essentially, the marking, your marking will be on the device. You can put dots or you can put tally marks, or if your marking is on the paper, you have your tally marks here. So if this is being used reused 3 times, I put another mark there, 3. So I know how many times it's being used. Now, how do you track it to the patient? You have your sterilization indicators there on each device or on each label. Stick that in the master register. That's what we're doing. We're sticking it in the master register and we write down the unique ID number. So on the sterilizer indicator, there'll be some space on the side. There's a small, that big, really small indicator. I will write down that this is AN and I will write 3. So I know it's item which has a unique number AN and no other item has AN. So with a 6 French cannula, I know it's a 6 French cannula. I've written 6F AN3. So I know this particular patient on their sheet. So it's a master register. So imagine this is your register in your OT, and you have a list of patients. You have a sticker of the patient, what surgery or procedure they've done, date and time and everything. Under that, give a good space. Stick these labels, sterilization indicators, and write down this French, this is the unique ID number, and this is the number of times it is used. Either that or have a nice Excel sheet. We've got an Excel sheet with about 34 columns. So we just keep adding on depending on the number of things. So there is no way you can actually miss it. So going back in time, you can check it.
Yeah. And do you want to share something about the NanoBar Codes?
Oh yes, the NanoBar Codes. Yeah, that's a technology which has come into the market. I would warn you, it's very expensive. So if you're, I'll use, so if you've got this device, it can actually imprint a barcode which is literally twice the size of the pencil tip. So it'll be a barcode imprinted on the device. It doesn't cause any change in the structure. It's imprinted and it's compatible with materials, but it's quite expensive. So I think when people use it more and more, the cost will go to come down. So that can be read by a scanner and automatically, that's the automated barcode system. I don't think many hospitals are still in the are able to get it yet because of the cost, and you need a complete setup. But I'm sure with time things will improve.
Yeah. Thank you so much, Dr. Vijay, but I'm not letting you go with that alone. Want you to help us understand a little bit of reprocessing of something similar but bigger, where the need is different, where the objective is different. We're looking at the reprocessing of endoscopes. Okay, so can you just take us through what is the difference? What are the steps in reprocessing of endoscopes or any scope? So various scopes that are there used in the hospital, and how are they going to be reprocessed, and what are the steps involved in each of these, and what is the criticality, and which step is the most crucial? So I
Yeah.
think I laid down a lot of questions. Yeah.
Okay, so no issues. So what we went through so far were single-use devices where the manufacturer says you cannot use, we don't recommend you using it more than once for whatever reason. Now endoscopes are meant to be reused, and here the advantage is the manufacturer will actually tell us that it's compatible. This particular solution is compatible with X scope and everything. So the steps, I would say, the first foremost step is as soon as the scope comes out of the patient. So again, my wire comes in handy. Scope has come out of the patient endoscope. It's wiped down to take off all organic matter, wiped down straight away to get rid of the organic matter, because as we have heard and as we all know, cleaning is very important. So organic matter, then it goes on to your cleaning process. Your cleaning could be manual or automated. If it's manual, again, staff safety, separated room, you have to have exhaust systems because you've got other corrosive materials there. So good cleaning to make sure it is reprocessed properly, good cleaning, and then you go on to your manual cleaning, enzymatic cleaning, and then you go on to your high-level disinfection. So here we are talking about high-level disinfection for endoscopes. So endoscopes meaning upper GI scopes, lower GI scopes. That's what I generally talk about endoscopes. When it comes to bronchoscopes, your high-level disinfection may not be sufficient. So that's when you go on to sterilization. So again, you can't use heat for sterilization. You would have to do something like an ETO. The challenge there is ETO takes that many hours. I have only two bronchoscopes. How can I do it? So schedule your cases appropriately, because we are seeing more and more evidence that high-level disinfection is insufficient for bronchoscopes. We have been using it for many years, and we have learned in our hospital that we've got, by doing high-level ETO sterilization, we found out that hospital acquired infections due to bronchoscopes, the rate has come down significantly. So schedule your bronchoscopes. And also, just to bring in my previous topic, there are single-use video bronchoscopes. Okay, it looks very much like a bronchoscope. It's a video bronchoscope which has a gadget which comes along with it. The manufacturer says they are single-use. However, in an Indian scenario, we know that we can't throw away with it. It costs about 30,000 rupees. Therefore, we have decided to put it into the single-use device category. So for the last 4 years, we've been reprocessing our single-use bronchoscopes. Again, same thing, the committee sat and we said, okay, let's reprocess this 5 times. Then we said it's working absolutely fine. We had no problems with them. And while you're introducing something like a bronchoscope, which is supposed to be single-use, it's a very complex scope. So you'll have multiple channels, high chance of organic matter, bacteria to stay by. So what we do is, before using the scope on a patient, we put saline through one end, take it out through the other end. So that's my scope. That's going to the patient. This is the other end. I put saline here, take it out into a sterile container, and then that goes for culture. So we call it a pre-BAL sample. Right? So we compare the pre-BAL sample and the post-BAL sample, and that gives us assurance that that particular bronchoscope has been sterilized properly. So just to tie both together. And in coming back to your question, Dr. Jayalakshmi, your second part of the big question. Yeah. Okay. How do we know that what are the most crucial parts of cleaning up any endoscope?
And endoscopes.
Yeah. So cleaning right after the procedure is very crucial. And then you take it away from the patient area in a trolley. Don't hang it and take it. It should be in a trolley because you don't want things dropping on the floor while the patient is moving here and there. Take it to a separate room. It's cleaned properly. Cleaning, cleaning, cleaning. I would emphasize on cleaning. Very, very important. By trained personnel, no shortcuts. Give them adequate time. Do not let them not be pressurized to clean it soon, and then it goes for your enzymatic clean, and then of course the high level disinfection. High level disinfection, you have multiple products in the market, so you choose something which is good and which will work. Now you have to use, for instance, let me use the take OPA, orthothialaldehyde, for an example. So orthothialaldehyde is the solution we are using. So you pour it out today, and how do I know it works? I have a litmus paper. So sorry, I have only a pencil with me. So this is my
We
litmus
presume
paper.
it's a paper. Yeah.
Yeah, imagine it's a paper. So dip it into the solution. First thing in the morning, dip it into the solution and check whether it changes color. Okay. If it changes the color according to the manufacturer will say purple is good, some manufacturers will say blue is pass. Make sure the manufacturer of the solution and the manufacturer of the strip is the same, because I can't use company X strip against company Y product. You will not get a result. So every morning, check to see if it has the minimal effective concentration, MEC. Only if it passes the MEC test will you use the high level disinfectant for that day. Again, the number of days it will be effective depends on your degree of cleaning. More organic matter, more ineffective it becomes, and you have to chuck out the disinfectant much more quicker than before. So most companies would say 14 days of shelf life. So on day 15, I put my litmus test, and it turns color. It's very favorable. And the company said 14 days. I will still chuck it out. I will not reuse it beyond the duration specified by the company, regardless of it passing or failing. And please maintain a log register of that with the name of the person and the signature and the employment number, date and time when they have checked it, because that gives accountability. Because you cannot save those litmus strips. If you keep it for about 5 days, it changes color. So you have to have a register for that. And then of course, after disinfection, store it safely in a cabinet and then reuse it.
Yeah. Thank you so much, Dr. Vijay. We're not going to let you go again. So I want to ask you some more questions on this. So what's the environment? You said something, you need to have a specific environmental control while processing these bronchoscopes,
Correct.
isn't it? So what is that environmental requirement while processing these bronchoscopes?
Sure. So most of the high-level disinfectants are toxic. So it's the air that they give out, like for instance, orthothialaldehyde, you walk into the area, you can smell it. Glutaraldehyde is even worse. So you need a separate room with a good exhaust so that the person sitting there and processing the item for 6 hours or 8 hours in the day is safe. So ideally should have negative pressure, good exhaust, and some of these items are toxic. So for instance, OPA will be neutralized with glycine before discarding it. So please you follow the recommended manufacturer's guidelines on discarding these disinfectants, because that is crucial. And also separate room, and make sure that our staff are safe. So that's essentially about the environment. And the environment should be clean, free from clutter. So only what needs to be in a room should be in a room, just like in CSSD. Free from clutter, just what you need is there. Only the right personnel should be there. A lot of training, emphasis on training again. Yes.
Thank you so much. What about the water?
Okay. Yeah, the water. Yeah. So yeah, the water, we must ensure that the water meets the standards. So it should be of RO water of good quality. Now, when it comes to automated reprocessing units, they have very, very stringent criteria for pH, for TDS, and the more TDS is the total dissolved solids. So high, like for instance, your borewell water will have a higher TDS than your river water. So higher the TDS, lesser the efficacy of cleaning and more, I mean, it causes more problems, to be honest. So just make sure that your TDS is actually within the limits. So sometimes you may have your reverse osmosis decreases the TDS like we do in most domestic RO plants, but here it's in a much, much, much larger scale. So the water coming to your endoscopic unit or your reprocessor, it should be checked on a frequent basis for its pH and TDS. It should be compatible with the manufacturer's recommendation for the particular reprocessing unit. Yeah, and then final things would be an alcohol rinse for most things. Yes.
Thank you so very much.
One thing I want to tell everyone: do not be pressurized by the operation theater or by the end user saying that I need the item now. Just two-way communication. And if there's some software which tells them, yeah, that is in that machine, it's going to take another 5 minutes, they will know. Because the last thing a surgeon or any clinician wants is an item which has been pulled out of a sterilizer for some reason, by whatever hook or crook, and be given to them just because someone made a big noise.
True.
So they will respect, I've seen people, I mean, even senior people in the organization who people are scared of, they actually respect and say, thank you for letting me know. That's all.
Yeah, that's right. That's right. Yeah. Thank you very much. So this is fantastic that you have reprocessing of single-use devices. Now we've done with reprocessing of our endoscopes as well. Thank you very much, Dr. Vijay. It was excellent, excellent, both your presentation on the single-use as well as how you help us understand the reprocessing of endoscopes as well.